Hello, my name is Rebecca Fry, and I am an RN educator in the operating room. For my presentation today, I've decided to discuss diabesity, which is a new term used to describe someone who has diabetes and obesity. It's a tongue twister, too. This is a global epidemic. I will focus on the adolescent age group. The reason I chose this topic is because I have an 8-year-old son, and as his mom and as a nurse, I worry about his health all the time. There is obesity in the family, and I want to do as much as possible to help prevent him from becoming a diabesity statistic. Additionally, we live in an area of Pennsylvania where diabetes and obesity are rampant. The city of Reading has become a largely Hispanic population, and since I work at the local hospital, I see these types of patients frequently. I can see myself presenting this information to a group of students or teachers at my son's school or a school in Reading. School involvement in prevention of diabesity through exercise programs and changes in meal offerings is paramount in this fight against diabesity. This information would also be helpful if presented to a group of young patients, such as during a support group for weight loss at the hospital. During this presentation, I will focus on the statistics for diabesity, how diabesity affects various body systems, modifiable and non-modifiable factors of diabesity, services and nursing care interventions to prevent and treat diabesity, treatment plan for the student or patient with diabesity, and how technology can help in the implementation of the treatment plan. And now I present Diabesity, a global epidemic from head to toe, prevention strategies for healthcare providers and parents. The term diabesity can be used to define the majority of obese people with type 2 diabetes. The combination of these two diseases is especially hard on the body, as I will describe today. Unfortunately, today's world can be detrimental to children, and negative effects such as hardened arteries and diabetes have been found in young children. Each body system and how it is affected by diabesity will be discussed throughout this presentation. The worst part of this diabesity epidemic is that children's lives are being shortened by these once-only adult disorders. The following slides will show the most recent data I could find regarding obesity and diabetes and just how prevalent these disorders have become from a worldwide perspective and then from a local perspective. Why is diabesity such a concern? Childhood obesity has the tendency to lead to negative health consequences in adulthood, including obesity, heart disease, insulin resistance, atherosclerosis, and many others. Almost every body system can be involved. Lifestyle changes over the last 20 to 30 years have created an obesogenic environment where obesity has become more than the norm. There is increasing technology such as iPads and game systems for children and adolescents, making for less physical activity. Supersizing meals on the go means ingesting more caloric-dense foods in a short amount of time. These are just a few of the factors of the obesogenic environment. The obesity statistics globally. According to the World Health Organization in 2014, these are the most recent statistics I could find, the worldwide prevalence of obesity more than doubled between 1980 and 2014. More than 1.9 billion adults 18 years and older were overweight. Of these, over 600 million were obese. Overall, about 13% of the world's adult population, 11% of men and 15% of women, were obese in 2014. In 2013, 42 million children under the age of 5 were overweight or obese. Obesity statistics for the United States. For adults, this is from 2015. This is the most recent CDC information, as you can see. For adults, more than 1/3, which is 34.9% or 78.6 million, are obese. Non-Hispanic blacks had the highest prevalence of self-reported obesity at 38.1%. Ages 2 through 19, about 17% or 12.7 million are obese. The highest rates in Hispanic children and adolescents, which is part of the reason I want to focus on the Hispanic children. I should say Hispanic children and adolescents. Adolescents are really my focus for this presentation. Obesity statistics locally. I live in Pennsylvania, and according to the CDC, 30% of the entire population of Pennsylvania is obese. 36.7% are self-reported obese Hispanics, which again, there's the Hispanic population that is obese, and 29.2% are self-reported obese whites. Obesity is more common in the rural areas for many reasons. They have less food choices, there's more poverty, there's less access to health care and preventative service. The schools offer more soda and candy in vending machines. For Berks County, Pennsylvania, which is where I live, 28% of the adults are obese, and 13% of low-income preschoolers are obese as well. Diabetes statistics globally. 382 million people were diabetic in the year 2013. This was expected to increase to 592 million by the year 2035. Diabetes statistics for just the United States. Total of 29.1 million people, or 9.3% of the population, have diabetes. 21 million have had their diabetes diagnosed, and approximately 8.1 million go undiagnosed. So they could be having diseases getting worse and they don't even know it. Diabetes statistics locally for Pennsylvania. 9.6% of adults in the year 2014 had diabetes. And in Berks County, Pennsylvania, it's higher than the state percentage. 11% of adults have diabetes and 7.4%, depending who you look at. So between 7 and 11% in Berks County. I couldn't find a year for the NICHQ, so that's why I put the CDC 2013 statistic there. So what do all of these numbers mean? And how does diabetes affect the body, especially in the adolescent age group? This is my concept map, which describes how many of the factors that contribute to weight gain are cyclical. For example, when an adolescent is overweight, there tends to be increased bullying, which is over on the right-hand side of the screen. They get made fun of, which then increases their mental stress, increases their self-esteem, it makes it worse, and then they also get depression. With that depression and stress comes increased cortisol, which increases their abdominal fat, increases their weight, and this cycle continues. They get bullied, they get stressed out, more cortisol, and it just goes around and around. Also within that loop is the increased caloric consumption. They will eat more food, which in addition will increase their weight and affect their obesity. As healthcare providers and as parents, breaking these cycles is critical to breaking the cycle of obese children ending up as obese adolescents, ending up as obese adults. This will decrease their chance of developing diabetes as well, because research has shown they go hand in hand. Let's take a look at just a few of the potential behavioral causes for diabetes. It's a no-brainer that when one consumes more calories during the day than they burn with exercise or physical activity, that the person will gain weight, whether it's a child, adolescent, or an adult. Eating quickly due to our busy lives has a negative effect on metabolism, and it limits the thermic effect of food and causes weight gain over time. Sedentary lifestyles have compounded all of these effects. So you can see on this slide, we have increased technology, which can decrease the physical activity of the adolescent or the child. They sit and play video games. They don't burn as many calories. The next bullet talks about the fast food, the high caloric intake. It's more concentrated. It limits the thermal effect of the food, which affects your metabolism. Sleep deprivation. If you are playing your technology late at night, you get less sleep. The next day, you're going to have more of an appetite, and then you're going to have increased caloric consumption, which then leads to weight gain. So again, contributing to the cycle of diabetes and diabesity, I should say. Now let's start to look at diabesity from head to toe. Looking at the neural and sensory areas, there is a clear link between sleep duration and risk for obesity in adults and in children and adolescents. Sleep apnea is 4 to 6 times more likely to occur in an obese adolescent than in a lean adolescent. Additionally, appetite regulating hormones called ghrelin and ultimately caloric consumption are affected by sleep duration. The less sleep a person gets, the more hungry they become. Many resources have discussed obstructive sleep apnea and its effects on obesity and insulin resistance, and possibly the development of type 2 diabetes, which equals obesity. Diabesity. Sleep apnea comes from increased neck and chest mass, making it difficult to breathe. Metabolism is affected by the temperature of one's home. Amazingly, I had no idea. This is something I never knew until I did research on this topic. Warmer environments in the home have contributed over time towards the development of diabesity. If an obese adolescent has one of these problems, such as sleep apnea, unless they receive treatment, more than likely they will have it as an adult. Obstructive sleep apnea can lead to high blood pressure, heart disease, pulmonary hypertension, and poor quality of life. Looking at the psychosocial aspect, a lot of things under this topic. As with many factors in diabesity, the adolescent can suffer many of these psychosocial symptoms, ranging from lower self-esteem than their lean counterparts. This can lead to depression or anxiety, possible substance abuse, and the cycle continues. Research has shown that some obese female adolescents engage in early sexual activity that expose them to more diseases. Many of these factors affect how successful the adolescents become as adults. The obese adolescent will more than likely have less job success, lower incomes, and be less likely to marry. A lot of times, diabetics in general feel different than other people because they need to check their blood sugar, give themselves shots, so they feel different from their friends, and that can also contribute to the depression and anxiety that they experience in adolescence. Not to mention all of the changes that are going on hormonally, which we'll discuss in a little while. In the musculoskeletal system, the obese adolescent and adolescents and children are more prone to broken bones, especially hip fractures, due to the increased weight supported by the frame of the body. The hip or the femoral head can actually crack, causing separation and decreased range of motion. As we stated, being an obese child or adolescent can lead to obese adults, and the problems these obese children and adolescents have can continue into adulthood. A prime example is osteoarthritis. They can also have malalignment of their lower extremities from all of the weight in their legs. It tends to bow their legs a little bit. Also, joint pain is in there. The endocrine system. The The adipose tissue of an obese adolescent will express a sex hormone producing enzyme, leading to hyperandrogenemia, which is a lot of extra hormones in the blood, and hyperinsulinemia, a lot of extra insulin in the blood, and insulin resistance, not making it work as well. Stimulates the androgen and estrogen production by the adrenal glands and the ovaries. There's also an increase of free testosterone, and this can lead to menstrual abnormalities in the female, such as amenorrhea, metrorrhagia, and polycystic ovarian syndrome. There are many changes in the cardiac structures and the hemodynamics of a diabesity person. There's an increased blood volume and increased cardiac output, which is caused by the heart structure changing and the function changing. This leads to cardiomyopathy, and the heart does not work as well. Dyslipidemia and hypertension are the two most common cardiac comorbidities. In obese children, serum low-density lipoprotein, cholesterol, and triglycerides are increased, which is a bad thing, and the high-density lipoproteins are decreased, which is, you want the opposite, meaning there's an increase in fatty acids made by the visceral adipocytes, and hyperinsulinemia that promotes the LDL and triglyceride synthesis by the liver. Obese children have a threefold higher risk of hypertension than the non-obese. Other contributing factors to hypertension are hyperactivity of the sympathetic nervous system, insulin resistance, and abnormal vascular structure and function. As far as the vascular system, the number of children with type 2 diabetes has increased tenfold over the last 20 years. The risk for micro and macro vascular changes could be they'd end up with retinopathy, nephropathy, neuropathy, and atherosclerosis. Obviously, all of these big terms that I'm mentioning, if I was to present this to a school or to the hospital, I would obviously explain a little bit more what these terms mean because they would have absolutely no idea. So I would obviously use a little bit smaller terms for them to understand if I was to present this there. For the respiratory system, there are substantial increases in asthma rates for a period of 14 years, increasing from 74% in the age group of 5 to 14. The substantial increase in obesity, coupled by this alarming increase in asthma, has tipped off researchers that there may just be a link between obesity and developing asthma. Some possible causes are related to other problems in the obese child and adolescent, such as poor diet, reflux, or the hormonal abnormalities. Other respiratory problems in the diabesity person would be the intolerance of activity and the shortness of breath. In the gastrointestinal system, the obese person especially has a risk factor for gallbladder disease. They also can have a risk for hyperinsulinemia. If any adolescent, child, young adult has right upper quadrant pain, they should initially rule out the gallstones. Since I worked in the operating room, I've assisted in taking out hundreds of gallbladders. And a lot of the times the surgeons would say, it's the 4 F's, female, fat, fertile, and 40. Those were our little ways that we'd remember. Usually those are the types of patients that they get their gallbladder taken out. Additionally to the gallstones, 1 in 3 obese kids have fatty liver disease or hepatic steatosis. The key here is prevention, prevention, prevention. The goal is to avoid obesity and diabetes altogether. In order to do that, we need to take into consideration the following strategies. The most important things to change. We need to make lifestyle modifications. That has to do with different meals, different foods, how we eat our meals, the types of exercise, the amount of exercise we do, and decreasing the amount of technology in the terms that the kids aren't just sitting with their iPads on the sofa. If the technology is interactive, if they are outside playing some sort of game with the iPad, they're up and moving around, that's a little bit different. It's more concerning when they're sitting on the sofa just playing their iPad for hours at a time. So, talking about interventions and a treatment plan, there's a couple different ways that we can go about this. The first way and the most important way is to get the parents involved and have parent engagement. This can help to prevent their children from having weight gain, or it can assist them in helping their children to lose weight, children or adolescents. I say that synonymously, interchangeably, I should say. In fact, parents and family units are vital for preventing weight gain to begin with. Research has shown that when parents are obese, children are oftentimes obese as well. If parents model healthy behaviors such as healthy eating and exercise, the children will most times follow. Research has also shown that if families eat meals together, children are less likely to snack between meals and they will eat healthier. Eating breakfast regularly, avoiding snacking and sugary drinks, and monitoring portion sizes are all ways to prevent diabetes. Turning off the television at mealtime helps control eating because you're more cognizant of the fact that you are full rather than watching the television and not taking into consideration the body signals that your body's telling you. Additionally, less technology time is important. This technology time, especially having a TV in the bedroom, can affect the amount of sleep that the child and adolescent get at nighttime. So decreasing those at nighttime is especially important to promote sleep. Physical activity should be 20 to 30 minutes a day in addition to the physical activity at school. Some families are stuck in their ways and parents do not think of their children as overweight or obese, especially if it's normal within their household. Sustained lifestyle modification is different, especially in certain family dynamics. Screen time should be limited to 1 or 2 hours a day. We all know that children need more sleep than adults, and the more sleep the children get, the less likely they are to overeat. Parents play a part in breaking the cycle with all of these lifestyle modifications. School modifications. School can play an integral part in decreasing obesity in children. Decreasing soda, junk food offerings at lunch, and vending machines is a good start. There should be minimum standards for physical education, and schools should follow these requirements. Schools should promote healthy meal choices, offer less junk food during the meal. They should promote healthy fundraisers. Sorry, there's a typo. They should promote healthy fundraisers instead of pizza, ice cream, have something different, or not food at all. They should have education classes for students to introduce them to healthy nutrition early. And then there was an article I found from the United Kingdom. This author presented a 10-point strategy for children and adolescents. Some of the points included continued measurement and assessment of children in schools or general practice, meaning the doctor's office, to identify a high risk for and identify overweight or obesity early on. That's really important to identify the problem early on. Assessment of knowledge about a diet and physical activity levels. Schools should become familiar with the child in order to set manageable goals in accordance with their lifestyle. So just because you tell somebody to go do more physical activity at the park, maybe they don't have a park nearby, and that's not a manageable goal. It's not going to work for them. And provide support and monitoring of the progress. You can't just tell people to go change the way they live and then say, see you later, and not check back with them. That's not going to work either. You need to provide support. If everyone in the United States would adapt this 10-point strategy, now I did not list all 10 things, but maybe the obesity rate would decrease. Healthcare providers. That's what we are. We are charged with early recognition of obesity and diabetes risks. Early recognition by healthcare providers is extremely important because some families, they don't know any better. Well visits in the pediatrician's office should start as an infant and continue through adolescence. We talked about that in the prior slide with schools. Schools can, send home notes all the time. I get notes for my 8-year-old who is 4.5 feet tall and 75 pounds that he is obese. When you look at the child, I have a picture later on. To me, again, maybe this is me just being me, he does not look obese. So, they're going by the BMI and, they're trying to alert me to the fact that according to the numbers, he's obese. Anyhow, get a little off topic here. The pediatrician's office should start measuring as an infant, continue through adolescence. Measuring the BMI every year is important. If sleep apnea is questionable, a sleep study would be required. Treatment would be performed, such as removing of tonsils and adenoids. Referring to a pulmonologist would be important if this surgery does not work. To evaluate children, if their BMI is in the 85th percentile or higher, they should get lipid profiles every 2 years. This is not something that's done on everybody. Hypertension treatment should be behavioral, like diet and exercise. Medication should only be given if the case is really severe. Be hypervigilant at puberty because the increased growth hormone, we should check blood sugars in the kids at risk. We should be screening for type 2 diabetes if the BMI is in the 85th percent or higher. And if they if they do have other risk factors, such as a known family history. Metformin is used to treat a fasting blood sugar between 126 and 200. They give insulin if it's greater than 200. Liver function testing should be done every 2 years, starting at age 10 for BMIs over the 95th percentile, or for those in the lower bracket with risk factors. We should also be monitoring where the child lives, because if they live in a more rural area, they might need access to healthcare. They might need to do computerized things. They have those, doctor visits online now. Maybe they could use that kind of technology to help, call a doctor, like phone a friend, phone your doctor. We need to be providing education for the diet and exercise, weight loss to the individual and to the family. That's really important. And like I said before, we can also provide support during the weight loss regimen. I already talked about asthma, that's one of the things that kind of goes hand in hand with obesity. If there's a question about asthma, we're going to do pulmonary function testing. And also, if there's a weight management center in the area, you can give them a referral. They don't always do surgery, but they also have medication regimens. So whatever the doctors decide, that's what they can go ahead and do. Just like the advent of wearing seatbelts all the time, instituting major changes and overhauls in the mindset of America will take some work. Little by little, we will save lives. Prevention is the biggest factor here. If we prevent the child from gaining weight, we've prevented the harm to their body. Hopefully, we've prevented harm to their bodies. Some of the things that the government and the food industries can do: offer prevention strategies, TV commercials, computer ads, things like that to help prevent gaining weight, changing their lifestyles. Have child-friendly labels so that the kids would be able to read it, put pictures on it, something that would be easier for them. Obviously, adolescents can read, but do they know what it means? and advertising to promote more healthy foods. During the cartoons, during the teen shows, don't advertise junk food. Advertise something healthier. So some more serious interventions I alluded to a little bit ago. Bariatric surgery. That was another reason I picked this topic, because I used to help perform bariatric surgeries, and I did a procedure on a 16-year-old one time, and I thought to myself, this adolescent is probably, it was a female, is probably not done growing, but here we are doing surgery on her. Does she really understand all of the lifestyle modifications, including medications that are going to be required of her after this surgery? So that was one of the other reasons I was interested in doing this topic. It appears bariatric surgery, according to the research, can be a great way for adolescents to lose weight if they're struggling with the behavioral modifications. Surgery should only be performed on adolescents who have stopped growing and who are in the high-risk obesity category. Generally, there was one meta-analysis that included over 600 studies included over 135,000 people. It demonstrated that type 2 diabetes was resolved in 78% of the cases. That is tremendous. A newer procedure in my area is called the sleeve gastrectomy. It's getting to be pretty common now. This reduces the levels of ghrelin, which is the hormone that stimulates the appetite. I personally know a few people who have had the gastric sleeve, and they are no longer on any medications for their diabetes, and they have lost a tremendous amount of weight. On the other hand, I do know another person who is terribly sick. She has lost way too much weight, and she vomits with large meals, more than 1 cup of food. So there are pros to surgery, and there are cons to surgery. So this is not a late decision. It needs to really be discussed with the patient. Selection criteria is extremely important in this process. Operating on adolescents is a delicate subject, as this group of individuals may not completely comprehend the need for vitamins and supplements the rest of their life. I said that already. And it is not just the surgery that has the impact. They also need to have their lifestyle changes, such as better diet, increased exercise, to make the most of this option. No matter what is decided, each decision is very individualized, looking at their family history, their family support, their attitude, strong will of the adolescent who will go under the knife. As I mentioned, it's not just the surgery that makes the difference. Those who follow through with the diet and exercise plan along with the surgery are the ones who succeed. Medications can be used for weight loss and to control blood sugar if all else fails and surgery is not an option. Orlistat is the only FDA-approved drug for patients 12 years and older. The only weight loss drug, I should say. Metformin has been known to control blood sugar, but it's also been noted to help patients lose weight if there's significant hyperinsulinemia or a family history of diabetes. The last slide is a picture of my family. This is partly the reason for me doing this. I have 2 nephews and a niece. On the left-hand side, you can see my brother Ben and his wife Ange and their 2 kids, little Brooks and little Grace. I'm in the middle with my son Evan. As I was saying earlier, they send the obesity letter home to me. He does not look obese. He's super tall, he's super muscular, but he's obese. And then on the right-hand side, my brother Will, his wife Amy, and their little boy Ike is in the background. So this is, part of the reason I did this. We can't have all of our children growing up in this obesogenic environment. We need to provide education to them and do our best so that they don't end up in the grave before we do. Thank you very much. I hope you enjoyed my presentation. Here's a few of my references. For some reason, I could not get that underline to go away, so I apologize. Thank you very much.